figure out what's the cause of it. Okay, there's two kinds, mechanical and non-mechanical. Mechanical is where the bowel is partially blocked by problems outside the intestine or in the intestinal lumen. So, what could block an intestine?
Hot wheel.
What did he say? Okay, a gerbil.
Whoa. Hey, I didn't break the rules that bad.
Pool. Worked in the ER. Okay.
Yeah,
now,
there's a lot of people that get a lot of
adhesions would be a
stuff.
good example. Prepare yourself. The world's the world. Adhesions, tumors might.
I like polyps.
Hernias and impaction. So there's your milk and molasses, I guess.
Yep.
Enema. Those would be examples of mechanical obstruction. But then there's non-mechanical. What's a paralytic ileus? Paralytic ileus. What do you think paralytic means?
No.
You guys will do better on tests and stuff if you can break words down. Paralyzed.
And then an ileus is just an obstruction.
And ileus is like the ileum, you know, okay, kind of paralyzed. If you guys take a second when you don't know words and do that, okay. Yes. And so paralytic ileus is decreased or absent peristalsis. But anyway, non-mechanical obstructions can be partial or they can be complete. So there's not an actual physical obstruction like the tumor or the adhesions or something like that, but it's the ileus and the paralysis. Peristalsis could be absent or just decreased, and then intestinal contents can slow or really back up. But part of it depends on all of this, where it's occurring. So, what's in the intestines? Ingested food, fluid, saliva, gastric, pancreatic, biliary secretions, and swallowed air. So what happens then, all those things accumulate at or above wherever the obstruction is. So what do you expect to see? Distension, so the intestines can't move or absorb their contents. And then frequently peristalsis increases because everything's trying so hard. But what happens when peristalsis increases is then so do secretions, and then the distension gets worse. The obstruction's there, the peristalsis doesn't help. So, what happens? The bowel becomes edematous, and plasma leaks into the peritoneal cavity, fluids trapped in that intestinal lumen. The ability to absorb fluid and electrolytes decreases, and sometimes hypovolemia, and definitely electrolyte imbalances. Can be mild, can be extreme, all the way to hypovolemic shock. And the ileum is the most common site. Okay, consequences: fluid electrolyte imbalances, acid-base, severe hypovolemia, renal insufficiency can lead to renal insufficiency or even death. And then peritonitis, it can result in bacterial peritonitis, and sepsis then, because that bacteria gets into the circulating system. But know that intestinal obstruction is a common and serious disorder, and it's associated with a significant morbidity. Causes of mechanical obstruction. Am I going too fast? Because we're going to whip through this thing.
We're good.
Yeah, but you still can't go. You have to hear inflammation, and that's not nice anyway.
No.
Things that cause mechanical obstruction: adhesions, tumors, Complications of appendicitis, hernias, fecal impactions, strictures, and we're gonna talk about Crohn's, but Crohn's can have strictures associated with that, or what if somebody has radiation therapy?
Yeah.
Fibrosis, and then vascular disorders, emboli, or arteriosclerosis of those mesenteric vessels. In the older adult, let me look. In the older adult, diverticulitis, and causes there we go. Post-bilious. Okay, two kinds. Interception of mechanical instruction. Interception. So that's where, and this is what you'll see sometimes in kids, and this is a normal healthy kid, this will happen too. It happens at home, and all of a sudden they have a lot of pain in their abdomen, and little did anybody know they won't go to the bathroom because they go in there and you don't follow them if they're 8, you know. So here's your bowel, and the other part just kind of telescopes right into it. And that's what, I mean, that can happen, it can be anybody, but you'll see that's the one you will see in kids. And volvulus is where there's an actual twisting of the intestines. So that's what happens. Okay, what kind of an assessment do you do? Well, as always, you want to get your history. You want to find out if there's any GI disorders, surgery, treatments. Don't forget family history is always important. If they've had pain, nausea and vomiting, hiccups. Why hiccups?
Swallowed air.
Maybe, but also this can stimulate that whatever starts hiccups, that reflex that starts hiccups, and I don't remember, but so hiccups are a sign of an obstruction. So you also want to assess their stool, have it been going, how often, what's it like. Physical assessment, you want to look for mid-abdominal pain, cramping, and if they have those signs, you think of a mechanical obstruction, vomiting, diarrhea, distension, high-pitched bowel sounds, sometimes no bowel sounds, but not regular bowel sounds. There's no definitive lab tests, but if you did lab, the values might indicate some dehydration, but it doesn't necessarily indicate obstruction. An ultrasound, a CT scan, and sometimes an endoscopy, but you're only going to do that endoscopy if they, if they're sure that there's no perforation, and if they don't think there's a complete obstruction. Questions? Am I going too fast?
That's Monday.
Yeah, but that doesn't mean I should go fast. Do I need to slow down? Please speak up. So, that's your, oh, no, I do it. There's a chart on page 1159 about nursing interventions, but big things, always we're trying to figure out what the cause is. Replace fluids, sometimes NPO, if necessary, an NG tube, and of course your responsibility, make sure it's working, make sure it's draining. Same with fluids, make sure they're appropriate in the site and all that. Manage pain. These people can have a lot of pain, and if they're nauseated and vomiting, you need to deal with that. Semi-Fowler's position is also good, and a lot of good oral care, and even of the nasal area if they have an NG, but frequent oral care. If it's a mechanical obstruction, obstruction, it's almost always going to require surgery. And I'm not talking about pre-op care, because you've had that lecture, but just be aware. So, and your post-op care aren't gonna be a whole lot different, except, you know, if you have some different tubes like the NG or whatever. Okay? Any questions about intestinal obstruction? Okay, now we're gonna talk about Crohn's disease.